Hello everybody. Today we're going to be talking about traumatic intracranial hemorrhage. We're going to discuss how to look for hemorrhage and how to determine what location a hemorrhage is in. We're going to look at the appearance of hemorrhage on CT and MRI. We're going to briefly touch on herniation as a complication of hemorrhage, and we'll look at diffuse axonal injury, which is a specific hemorrhage pattern. We have to adjust the window and level of our image by left-clicking and dragging with our mouse to accentuate the differences in attenuation between tissues. On the left, we have a 40-40 window and level, better for looking at gray-white differentiation, as we do in cases of infarction. On the right, we have a window and level of 180 and 90. This will make hyperdense hemorrhage more conspicuous. We need to evaluate the cisterns for subtle amounts of hemorrhage and for signs of herniation. Here we have the quadrigeminal plate cistern, the ambient cisterns. We have the suprasellar cistern, the interpeduncular cistern, more of the suprasellar cistern, and the prepontine cistern. Now hemorrhage will layer dependently within the interpeduncular cistern and within dependent sulci. So if you want to detect small amounts of hemorrhage, look at the interpeduncular cistern. One of the things we need to do when looking at hemorrhage is figuring out what space the hemorrhage is in. Is it intraaxial or extraaxial? If it's extraaxial, is it a subdural hemorrhage, an epidural hemorrhage, or is it subarachnoid, or a combination of them? If it is intraaxial, is it a lobar hemorrhage, or is it involving the deep basal ganglia? Are there any complications of the hemorrhage? And we need to think about what could have caused the hemorrhage. Here we have some diagrams of what these hemorrhages could look like. On the top left, we have an epidural hemorrhage, which is going to be convex and is going to not usually cross sutures. Next, we have a subdural hemorrhage, which is going to be concave, crescentic, and will cross sutures but not midline. Subarachnoid hemorrhage will extend to the sulci, as diagrammed in this next image. Subarachnoid hemorrhage can also layer with an interpeduncular cistern, as we just talked about. Here's a diagram of what an intraaxial hemorrhage might look like. Interventricular hemorrhage will layer posteriorly in the occipital horns of the lateral ventricles. And this is a representation of a prepontine mesencephalic hemorrhage. Our first case, we have an epidural hemorrhage. Notice its biconvex lens shape. And this will occur on the side of the injury, usually, the coup injury. These rarely cross sutures because the dura is attached to the sutures. 90% of these are caused by arterial injury and most commonly going to be caused by the middle meningeal artery. 10% of these epidural hemorrhages are actually dural venous sinus injuries. They're usually unilateral and again found adjacent to the site of impact where you're going to find skull fractures. In this case, notice how there's substantial local mass effect with effacement of sulci, subfalcine herniation of the brain to the left, with leftward midline shift. In this next case, we have a crescentic collection extending across the entire right side, hyperattenuating collection. This would be in the subdural space. This can cross sutures. This does not cross midline. This is often due to tearing of bridging cortical veins as they cross the subdural space to enter the dural venous sinuses. And these are more often a contra-coup injury on the opposite side of the impact. So this patient would have impacted the left side of their head, image right. Over time, the attenuation of hemorrhage decreases. In this patient on the right, we have a chronic subdural hemorrhage. In the midline, along the left aspect of the thorax, we have an acute subdural hemorrhage. On the left side, we have a mixed attenuation hemorrhage with areas of more acute blood mixed with older blood. When we have hemorrhage, we want to look for any signs of mass effect and herniation. In this case, there's a left anterior cranial fossa subdural hemorrhage and left middle cranial fossa subdural hemorrhage with effacement of the sulci. There's rightward midline shift, and centrally here we should have a suprasellar cistern. The effacement of the cistern is consistent with downward herniation in the brain. There's also a mass effect in the left prepontine cistern. The tentorium should be attaching right here, but there's brain beyond that, and that's left ungual herniation. Here we have a case of bilateral biconvex collections, hyperattenuating extraaxial collections, which would be consistent with epidural hemorrhages. Now, this is a very specific type of epidural hemorrhage because in this location there's no artery, but there is an anterior venous plexus within the middle cranial fossa. So this is actually a venous epidural. These are benign hemorrhages that do not require intervention and will not grow over time. Here we have a case of several different types of hemorrhage in the same patient. We have subarachnoid hemorrhage with layering within the sylvian fissure on the left. We have intraventricular hemorrhage layering within the occipital horn of the right lateral ventricle. We have subarachnoid hemorrhage along the cerebral sulci. And we have a subdural hemorrhage along the left tentorium. Notice how this tentorium is slightly more hyperattenuating than the right and has more of a ill-defined brush-like appearance. Here we have a more subtle hemorrhage. Within the left sylvian fissure is a small subarachnoid hemorrhage. Now the question will come up, what is the best sequence to identify subarachnoid hemorrhage on MRI? And it turns out to be FLAIR. On the left we have a fluid attenuated inversion recovery sequence, the FLAIR sequence, and we see abnormal hyperintensity within the subarachnoid space, extending within multiple sulci, most predominantly posteriorly. Fluid attenuated inversion recovery, fluids should be dark. The presence of abnormal hyperintensity suggests the abnormal material within the subarachnoid space, within the CSF. We can see susceptibility weighted sequences do not demonstrate hemorrhage within the subarachnoid space very well. Now there's a differential for abnormal signal in the subarachnoid space on FLAIR sequences. Number 1 is another case of hemorrhage with abnormal signal within the subarachnoid space, within the ventricles layering posteriorly. Number 2, there's abnormal signal within the CSF diffusely. This turns out to just be artifact from hardware. Number 3 is another case of hardware where you have dental hardware resulting in abnormal signal anteriorly. Number 4 is a case of carcinomatosis with tumor cells in the CSF resulting in abnormal signal. Number 5 is leukemia with abnormal signal within the subarachnoid space extending along the sulci. Number 6 is that case of hemorrhage we just saw. Number 7 is abnormal signal within the subdural space extending along the left falx and within several sulci in the left hemisphere. This is a case of a subdural empyema and meningitis. Abnormal signal on FLAIR could be representative of blood products, tumor cells, pus, or simply an artifact. Here we have a case of intraaxial hemorrhage where there's been a direct contusion of the left anterior temporal lobe. There is hemorrhage within the brain parenchyma surrounded by low attenuation edema. We note that this is the site of the impact where there's periorbital soft tissue swelling and hematoma, left sided retrobulbar hemorrhage with hypertonic material behind the globe, and left globe proptosis. Now, for looking for sites of contusion, we want to look at the inferior temporal lobes and the anterior aspect of the temporal lobes, and then the inferior and anterior aspect of the frontal lobes. These areas are most at risk for rubbing against the sharp inner table of the calvarium at the base of the skull. Now, this pattern of hemorrhage doesn't quite conform to what I just said. This is hemorrhage specifically at the gray-white junction. And this is a result of shearing injury between the gray matter and the white matter. This is diffuse axonal injury, and it has to do with the differing densities of gray matter and white matter, resulting in different accelerations in trauma. Diffuse axonal injury will affect the gray-white junctions, more anteriorly in the frontal lobes. And as you have more severe degrees of diffuse axonal injury, you have involvement of the corpus callosum, the splenium of the corpus callosum, and in very severe cases of diffuse axonal injury, you'll have the brainstem involved. Anytime you're evaluating for intraaxial intracranial hemorrhage, you want to look at susceptibility-weighted sequences. In the left parietal lobe, we see a small hemorrhage. Within the splenium of the corpus callosum on the right, we see a hemorrhage. And in the right subinsular region, this is another case of diffuse axonal injury. Now, it's important to remember that although we'll see mild degrees of hemorrhage on CT or MRI, patients with diffuse axonal injury can have very severe clinical symptoms, and patients can be comatose. To summarize, we've talked about the different compartments of hemorrhage. We've talked about mass effect and herniation. We've talked about evaluating for the subarachnoid space, the dependent locations on CT, and how hemorrhage looks on flare sequences. We've talked about the inferior and anterior frontal and temporal lobes being most at risk for contusion. We've talked about diffuse axonal injury and susceptibility-weighted imaging for evaluating for intracranial hemorrhage, intraaxial intracranial hemorrhage. Thank you so much for your time.